Thank you. Thank you, Dr. Fang. Thank you, Tanuj and APGS and AIOS to give me the opportunity to talk about my babies. So there are no financial disclosures, and we've taken informed consent from parents of the babies to use their clinical photographs. So in the next couple of minutes, we'll presume that congenital glaucoma has been treated with surgery. So once surgery done, what next? We look at when to call back, what to look for, how to evaluate whether EUA or sedation, and what disease progresses despite so-called controlled intraocular pressure in children. We need to look at the cornea and the axial length. And even if the disease stabilizes beyond the intraocular pressure for these children, we need to look for their vision, and their vision. So the first thing is, when is the eye patch opened? So now that we've started doing bilateral surgery, and this is something which COVID has taught us, the child gets very, very annoyed when he wakes up from GA and has both eyes patched. So we open it 3 to 4 hours after GA. And actually what we've seen, this is just about 3 hours after surgery, and you see how much clearer the cornea is. And this is the ecchymosis from the speculum still there. So if it's unilateral, we usually wait till next morning. We look for the cornea, the anterior chamber, any hyphema, and all of this will direct the next steps, usually of a combination of steroids and antibiotics for about 3 to 4 weeks. So what next? In 6 to 8 weeks, when the child comes back, the first thing we look for is the child's comfort. And the best thing to ask is the mother. So if you have a baby who was photophobic and unhappy, and then wants to look at you through the slit lamp, you know most likely she's all right. And similarly, this kid who underwent a gap actually, and this is next morning, and they're reasonably comfortable. So really going to do angle surgery apart from the combined trap we did has made a huge difference in the comfort of the children when we do that. Intraocular pressure, if possible, but we look at axial length very, very carefully, and we look at how we do that later. So of course, apart from the cornea, we look at the axial length and intraocular pressure. If we can do the eye care, it's made a lot of difference. But it's important to remember that in children, a Goldman apprehension tonometer is the most accurate measurement for IOP assessment. Rebound tonometry, we must remember, overestimates the intraocular pressure, and the overestimation increases with increasing central corneal thickness and increasing intraocular pressure. So these are things to keep in mind, but yet when you have a baby as small as this, an eye care is your best bet. So sometimes the IOP is normal, and that's when we look at axial length. And it's important that the change is important, not absolute values. So we'll just look at this preterm baby with retinopathy of prematurity, underwent both eyes LIO, and then required a lens sparing vitrectomy in this eye. Now, post LSV had ophthalmos. The problem was that the IOP remained okay, but the eye progressively enlarged. So nothing really was done except give drops. But despite that, if you can see that, now this is Sampoulos' chart, which we use. And this is plotted according to the age. So you can see that when we saw this axial length was increasing beyond the normal growth, and that's the caveat in children, because the eyes are going to grow. So you have to have a reference point against which you really measure the axial length. So this is what we do in our clinic. And then we did a combined trap with trap here because we saw the slope was beyond what normal was, and then it stabilized. And sometimes it does tend to go down, regress towards normal as well. So when would we start thinking of an EUA? When we think the pressure is high, and one of the clues is the axial length rising more than the normal growth, and look for loose sutures even if all else is okay. And we think that's very, very dangerous. So for instance, this baby underwent a goniotomy, had a bit of hyphema. 6 weeks later, looks all is well. But if you look carefully, there's a loose suture which is accumulating mucus, and this needs to be taken up and requires an EUA for just this. And we've learned this the hard way. This infantile PCG had a bilateral uneventful goniotomy, could not come for 2 months because came from Srinagar, that's in Kashmir, due to the lockdown. When they came back in 2 months, the mother said the cornea looked whiter than before, and that's why they came. Unfortunately, the ultrasound showed choroidal detachment, there was watering, there was hypotony, and to our horror, when we put in a speculum and looked at it, there was almost a corneal melt over there. and it required a patch. So we need to be really careful. If we think the child is not going to follow up, then maybe it's better to wait for surgery than operate and land up in a problem like this. So far it's so good, but we are keeping our fingers crossed now. The follow-up exams, usually the first exam is planned 6 to 8 weeks after surgery. If any intervention is planned, we schedule them accordingly. And if the examination is satisfactory, then subsequent EUAs or sedation are 4 monthly for the first year, and subsequently we do it every 6 monthly. And what do we look for? We always compare it with the pre-op status, intraocular pressure, corneal clarity, corneal diameter, again, any sutures, if there's a bleb, if we did a trabeculectomy or a tube position, if we did a drainage implant, the disc status, retina, but what we've also learned is axial length, refraction, and keratometry. And we do that at every EUA because it's an opportunity to see how the eye is growing. A word of caution in babies, we need to explain punctal occlusion very carefully, and it's very important to wipe off the excess drug. And we've learned that really hard way. This 6-week-old baby had a bilateral goniotomy done. We usually use betamethasone 4 times, both eyes, but to our horror, in 6 weeks, this baby actually gained 2 kgs weight. And when we evaluated, the ACTH was low, the cortisol was low, and we had actually induced a Cushing syndrome in just 6 weeks by just not probably explaining hard enough that the puncta need to be occluded and the excess drug needs to be wiped off. As Dr. Sirisha had talked about secondary goniotomy, so what do you do after trab with trab fails? This is a right primary congenital glaucoma and left Peters. You can see the Descemet's defect. Underwent both eyes trab with trab. The right eye seemed better, but IOP was not good enough. So we did an optical iridectomy in the other eye since it was under GA. But a goniotomy for the nasal angle cleared the cornea and stabilize the pressure. So sometimes even if you can't do it at the first go, but second go, maybe the cornea is clear enough to do it. Now, it's also important to recognize the risks of repeated general anesthesia in these babies. There's early in life, there's attention deficit, hyperactivity disorder, language processing, and cognition. So it's not enough to just say, let's do EUA 3 times a year or 4 times a year. So we evaluated an intranasal application of dexmedetomidine using an atomizer, and a quick video to show that this little boy is actually fast asleep in the post-op recovery. So we do it in the recovery under monitoring. The patients are fasting as for anesthesia. This is the atomizer that's available. A little bit has to be just squirted in the nose. They don't need intubation. They just need 1 pulse oximeter to monitor them, and you can do most of what you want to do. You can see how the child is fast asleep, and this is my senior resident who's going to go on with the entire EUA, including pressures and diameters and retinal status and whatever you want to do. So we found this to be a simple thing. After successful surgery in acute hydrops, for instance, if you have an acute hydrops like this, and you do a combined surgery, and then you do a goniotomy in the left eye, the child is now 4 years old, IOP is fine, disc is stable. But is our job done? Beyond the pressures, we can't forget vision. Retinoscopy, spectacle prescription, visual acuity assessment, visual access assessment, amblyopia treatment, and when they're old enough, visual fields. So this is our cornerstone of actual glaucoma management. We are in the business of vision, so just controlling pressure is not enough. This baby underwent an OPK. This one had Peters anomaly. OPK does bad. So we just did an optical iridectomy, and sometimes that is enough. Contact lenses are problematic. Remember, it's not easy. So when you have very high pressures, sometimes we need to do a refractive lens exchange, which is a clear lens extraction in this boy who had -22 in one eye. So to summarize, childhood glaucoma is a lifelong disease. It can manifest in myriad forms. So much is yet unknown, but ensuring good vision is our goal and not IOP control. But then we need to hold these children's hands for a long time. I acknowledge my seniors and my residents and fellows. Thank you very much.